of the most difficult and important, long-lived and urgent questions for all organizations. How should we balance centralization and decentralization? To explore that, we'll look at some recent COVID challenges. We could not have two better guides. Nelson Phillips is Professor of Innovation and Strategy at Imperial, co-director of the newly established Center for Responsible Leadership, and previously Dean of the Business School. His research spans entrepreneurship, organization and technology strategy, and indeed innovation. He's published widely for both academics and practitioners. He's also one of the most popular, effective, and in-demand professors across degree and executive education. He is, for example, co-director of the very highly regarded Imperial Executive Education Program, Leadership in a Technology-Driven World. Carol Proper is Professor of Economics at Imperial College Business School and President of the Royal Economic Society. Amongst her many achievements, she's twice won the extremely prestigious Arrow Award for Best Paper Worldwide in the field of health economics, as well as a CBE for Services to Social Sciences. Her research focuses on the factors that affect production and outcomes of public services with a particular focus on healthcare. Her publications in healthcare, for example, explain the effect of market incentives, the impact of environmental factors, the impact of good and less good management, and most recently, the impact of recessions on healthcare. Before I hand over to Nelson, I'd invite you to use the Q&A function to ask questions, which we'll go to after about 30 minutes. It is my great pleasure to first introduce Professor Nelson Phillips.
Thank you very much, David. It's a real pleasure to be here. Thank you all for joining us today for this conversation. So it's great to actually be meeting with you now today. We've been talking about this for some time, thinking about kind of the things we might share with you in this conversation, and looking forward to the questions and comments that you have. I'm going to take a few minutes and just talk a little bit about centralization, decentralization as concepts, both broadly in politics and society, and then more specifically in organizations. And then I'm going to turn it over to Carol, who's going to talk a little bit about this, what this means in the case of healthcare, particularly the NHS, and how this problem has both caused lots of difficulties, and when organizations get it right, how it does allow for the provision of really great services. But in the complex environment of healthcare, it's a great context to think about the challenge of trying to figure out what degree of centralization versus decentralization is right for what kinds of activities. And that's what we want to talk about today using that example. So really pleased that you're joining us. This decentralization, centralization debate is old. Henry Mintzberg said it well in his Structuring Organizations book, came out in 1979, saying the words centralization and decentralization have been bandied about for as long as anyone has cared to write about organizations. I thought it'd be interesting to look up and have a look and see where these words actually came from and where did they appear? And it's interesting if you have a look. The first uses of the word centralization actually occurred in France after the French Revolution, when the revolutionaries had taken over power and were trying to think about how to restructure the government to provide higher quality services. So this conversation about government services and degrees of centralization is as old as that. 1794 is the first mention of the word centralization in French. Decentralization came a few years later, and they both moved into English in the early 1800s. This whole idea of decentralization in a political and government sphere has been really a really interesting conversation about to what degree is decentralization a solution, to what degree is centralization a solution. The conversation went on very early on. Very extreme decentralization, of course, was a position occupied by anarchists in Europe for many years, of completely decentralizing everything, not even having a center. And then sort of in America in the 60s and 70s, of course, with the kind of social movements that were going on, there was much discussion of decentralization and the possibilities. People like Toffler, in Future Shock and the whole small is beautiful movement. We're all about decentralization at a government, in terms of government provision of service, and also in terms of the production of goods and services, local being better, small being better, decentralized being better, versus the very large centralized production systems like Henry Ford's car plants. So this is a really interesting and long-term discussion, both at a societal level, government, in terms of provision of government services, but then also, of course, as Henry's talking about here, Henry Mintzberg, it's about organizations and how, companies and other kinds of organizations, and how do we organize them, how centralized, how decentralized, to get the most we can. So let's begin just by being clear on what we're talking about. Centralized structures, it means that there's somebody in the center making decisions, that everything that happens is run from a center, from a person or a small group of people who make all the decisions. This is common in entrepreneurial ventures, where an entrepreneur founds a company, grows a company, and even when they get to be 150 people, he or she is still making every decision, signing every check, super centralized structure. And that's the star on the left in terms of those pictures. Decentralized, of course, pushing some stuff out and having multiple places where decisions are made. The more decentralized you are, the more points at which decisions are made, and the more points at which resources can be allocated. The more centralized, one or only a small number of people in the center making all the decisions for all the activities going on across the organization. There's some other stuff we're not going to talk about. Here's a networked form of organization. There's all kinds of newish kinds of ways of organizing. We're really going to stick to these two, centralized versus decentralized, as the basis for our discussion today. What's the potential problems? Well, overly centralized organizations struggle with flexibility, with being able to provide customized activities for localized problems. So over-centralization starts to have lots and lots of exceptions to the centralized processes and the kind of dictated activities, lots of local kind of cheating going on, lots of struggles around that doesn't fit us, that doesn't fit our problem, that doesn't fit our customers. Overly decentralized, well, the biggest problem is cost, efficiency. Pushing things out does require more more resources, and it also means that there's a loss of consistency across the organization. Different customers in different places have different experiences. For example, if it's a company. So this is, or if you have, say distributed, decentralized HR function in your organization, you have different departments having different HR policies. Is that okay? Well, that's the question for you. And to what degree is that okay? And maybe that's responding to local need, or maybe it's creating unfairness in the organization. These are the kinds of problems that arise. One of the most common things in larger organizations is to see oscillations back and forth between centralized and decentralized. When it's quite decentralized, everyone looks and says, "Oh, this is inefficient. This is there's no consistency. We really need to centralize this." Then they centralize it, and they over-centralize it, and then you have lots of the problems that come with over-centralization in terms of a lack of ability to be locally responsive. And then the people, after a few years, forget that they used to be, whichever is the opposite way, and then they move the other way. So you see these large organizations moving more centralized, moving more decentralized, moving more centralized in terms of many different aspects of their activity. And the thing to keep in mind all the time is it's not decentralized versus centralized. This is about a matter of degree. And this is the art. This is the where leadership has to really look and say, what's right for my organization? What's for different aspects of the activity in my organization? Where do we put it on this centralized versus decentralized? And how do we make sure we don't overcorrect when we think we're fixing things? Because that's the most common thing to see. Overcorrection one way, overcorrection the other way. One set of problems just replaced with another set of problems, and lots of cost moving back and forth from centralized to decentralized models. Decentralization has a lot of supporters. It's got a lot of supporters for a number of reasons. It's more flexible. You have a lot more flexibility, a lot more ability to move quickly in response to change. At a local level, as soon as there's any change, you can make changes. It's easier. Responsiveness to local realities. This gives a lot more ability to customize for whatever you're trying to do, whether it's HR, IT, or whatever. Lots and lots of innovation goes on in these decentralized activities. So you get to see a lot of potential for innovations to bubble up, although you have to have a system for capturing them and spreading them around, and that can be tricky too. And then probably one of the biggest things that people talk about with decentralization is resilience. This is This is a mapping of a very resilient organization. This is Al-Qaeda. This is a systems map of Al-Qaeda. Al-Qaeda is incredibly distributed. It's incredibly decentralized, and that makes it incredibly hard to get rid of, because even if you get one bit of it and get rid of it, there's lots more of it just that you can't get to from that point. So the resilience of these highly decentralized organizations can be quite an attraction. But there's lots of challenges, and this communication is one. It can be very difficult to connect together and get different parts of the organization talking to one another. If they're highly decentralized, they tend to go off on their own. They're not sharing best practices. They're not sharing information. Accounting and control systems become more and more complicated to try to capture what's happening in all these decentralized departments or whatever they are, or whatever the subunits of the organization are. And as I mentioned, the problem is you can have great innovation somewhere, but it doesn't get to everyone. And in fact, even if it's shared, because you're decentralized, there's no central person saying you have to adopt this innovation. So the not invented here syndrome means that great innovations don't spread out because there's no one saying everyone needs to do this, right? And then there's lots of inefficiencies. There's not integration of activities that, for example, might allow you to buy in bulk, that might allow you to align your activities to get more impact in terms of your marketing or any kind of activities. Because it's split up, you lose the efficiencies that come with scale. Right? So there's challenges and there's advantages and disadvantages of decentralization versus centralization, and this is this paradox. There is no perfect. There's just where on here gives us which kind of advantages and disadvantages and what best matches what we're trying to accomplish. There's a number of different proposals for how to think through this. This is one that I quite like, because it starts with just 3 simple questions. This is from McKinsey. It's called the McKinsey decision tree. It's really a good way to think about it. There's lots of others. And it's just saying, basically, things should be decentralized unless one of these is true. If one of these is true, then it's good to centralize. And I kind of, my personal preference, or my personal, I prefer decentralization generally. But that's also depends on your personality and what you like in terms of organizations and how they run. But what McKinsey's saying is, it should be decentralized unless one of these is true. So is it mandated? So sometimes things have to be centralized. For example, financial services, risk and control, government, various government bodies require a centralized system that makes sure that there's consistency across the whole organization and rules are being followed. If it's mandated, required by law, obviously centralize. Does it add significant value? And this is the real challenge. It's not just, oh yeah, that'll be better if we centralize, we'll save money. How much money? And show us. And most of the time, the gains of centralization are less than expected. So make sure they're quantified, and make sure you believe them, and make sure they're significant, because there's cost to centralizing. So make sure that and McKinsey suggests 10% is a good bar, a minimum bar, and you have to actually show where's that 10% going to come from. And what about risk? How risky is this change? Right? What is what potential risks are we expecting? Are there big risks? If there are, maybe don't do it, because unless there's really large value, or unless it's mandated, then maybe if there's significant risk, probably not a good idea. So this problem of centralization and decentralization is a central management issue in your organizations, whatever organizations you've been in. I'm sure you've come across this time and again. And I think the really interesting question is, how do we think about this? How do we position ourselves, and how do we avoid this oscillation between centralization and decentralization, which is demoralizing, expensive, and actually isn't getting us anywhere? Well, in order to start thinking about that in a bit more of a concrete way, I'm going to hand you over to Carol, and she will take you through some examples and some context in terms of the NHS to get us thinking about some concrete challenges of how we centralize or decentralize services.
Thank you, Nelson. And thank you to all the participants. I'm looking forward to hearing your questions. So, as Nelson said, I'm going to think about or illustrate really the centralization-decentralization dilemma in the context of the NHS, and in particular of recent events. So, Nelson, could I have the next slide? So, I'm going to first start by talking about a situation where the NHS has centralization, and that centralization really was imposed instead of decentralization, and probably we would have wanted to have more decentralization. So in a sense, the poster child, or maybe not the poster child, is the COVID-19 track and trace system, which we've heard an awful lot about in the last 7 months. So the kind of backdrop to this is that in the UK, public health is overseen by a national organisation, which is Public Health England. But generally, the idea is that public health will be delivered at a local level, because knowing about the locality, knowing about the outbreak of infectious diseases or of other problems like salmonella are generally delivered best at a local level. But and then again, as part of that, testing and tracing has been a key pandemic function. We've been told this since the beginning of the epidemic. Clearly, controlling any kind of epidemic requires us to know who is infected, who's not, and then following those people around to make sure they don't infect anyone else. In that context, the government response to COVID-19 has been really to move towards extreme centralization, at least initially. So basically, when the COVID situation broke, they moved to heavily centralize the track and trace system, and thereby, whether deliberately or not, ended up excluding the local public health function. But in fact, they did this whilst the existing central system had very few resources, because the existing central system wasn't really built to do a lot of tracking and tracing. And in early March, for example, Public Health England had 290 contract tracers only. And as the government's advisory body said, it had a capacity to cope with 5 new cases a week. So they were kind of left with this problem. So what did they do? So to build capacity, central government reached out to help from private sector organizations who they thought had capacity and are able to scale up rapidly. But in order to do this, they contracted out to many private organizations, not just one. So Nelson, can I have the next slide? So what I'm going to show you is a quote from somebody, a doctor, who was employed as a NHS tracer, a central tracer. And he wrote that, and this gives you an illustration of how many organizations were involved, the NHS professionals employed us as clinical tracers, but we were recruited by Capita, who are a private sector organisation, and placed with Public Health England. Then another organisation, Cytel, provided access to the tracing applications and systems. Synergy CRM assigned cases and held scripts. CTAS captured contact tracing information. Ring Central was used for voice calls, and Max Connect was used for storing knowledge about contracts. As if that wasn't enough, systems were accessed through Amazon Workspace. Training was initially through PHE's LearnSpace and then moved to Health Education's England Learning for Health. So that you can see that what happened in this response to try and get a central system working is that a large number of organizations whose systems did not talk to each other were brought in to help the response to the pandemic and to help with this specific function. So what was the result of all of this? Nelson, can I have the next slide? So the result was, and I think we all know this, the national system was very slow to take off. We read daily, or were told daily, of how few cases have been traced. Even now, the national system has a lot of leakage between someone being tested and their contacts being traced. So there was a kind of estimate taken in the end of September that by September, the system had ramped up to around 600,000 cases a week. Of those, though, NHS Track and Trace contacted only 4 out of every 5 cases. Of those, 4 out of 5 of those cases provided details of contacts, and 3/4 of contacts were subsequently reached. So if you kind of do the math on that, only 50 to 60% of contacts of known cases were advised to isolate. Is that a problem? Yes. An effective contact tracing system, according to SAGE and other bodies, traces about 80% of contacts of an index case of someone who's been identified. So it wasn't working very well even by September, but also I think the fact that we'd had 6 months of things visibly not working led to a widespread lack of belief in what was to be the UK's world-class track and trace system. And that's kind of a problem because you need the public to believe in these systems. You need public buy-in, as we know, to impose some of the very tough sanctions on people who have been in contact with a track and trace system. And decentralized systems that or systems that do this well, for example, in the case of Ebola or AIDS in South Africa, Ebola in Sierra Leone and Ebola in South Africa, know that you really have to enforce these systems. You have to enforce quarantining by individuals or changes in behavior by individuals. So that was the national system, but meanwhile at local level, there are local level public health functions. And in fact, Cumbria decided to continue, or were able to continue, with their local level system. And so at the same time, Cumbria's scheme is extremely decentralized. It's run by Cumbria. It has 93 local contact tracing teams, all of whom know their local patch. And they successfully reached about 97% of all contacts in late September, compared to 60% or so by national teams, simply by taking advantage of the fact that decentralization was a good thing. And there's a nice quote by the woman who leads this, who said that in August, the Department of Health, having decided that this centralization wasn't such a good idea, said that NHS Test and Trace will become local by default. And the local organizer of the Cumbria system, the head of that, said, we're still trying to figure out exactly what that means. So can I have the next slide? So to kind of push home this, I want to contrast our centralized system with the decentralized alternative of Germany. And to kind of point out that responsibility, so the system in Germany is responsibility for public health is at federal level, there are 16 of those, and at county level, there are 400 of those. And then overseeing that is one national organization, the Robert Koch Institute, which supports local delivery. Germany was one of the first countries to develop a diagnostic test of their own, which they were able to roll out quickly through a network of both public and private labs, so a very decentralized system to testing. They also did a national thing, which was they used their health insurance system to incentivize providers by making tests free. To increase contact tracing, they did some national things, which is they used paid contact tracers, and they also used military personnel. And obviously the military is a central function. But basically the system was run at federal and county level. So isolation and quarantine of cases was determined by local authorities who knew their local patch. In terms of the outcome, this clearly worked. As of May, early May, Germany had run just over 18 tests per positive case, which was higher than either Italy, Spain, the US, much higher than the UK, France, and the only country that was higher than that was South Korea. And by the end of August, they were doing over 1 million tests per case and have been argued to be able to keep down the death rates per infected case because of in part, this very decentralized system. Okay, so having talked about a situation in which centralization probably was not a very good idea, I'm now going to talk about some cases where the kind of opposite was the case. So Nelson, can I have the next slide? So now I want to talk about another function that the NHS does, which is NHS procurement. Procurement is really important in healthcare. It's the largest area of government procurement, 3 times that of defence. So there's 2 levels to procurement in the NHS. Services, things like services in hospitals and services provided to patients, are purchased locally. Goods are purchased centrally. That wasn't always the case, but has been the case for the last 4 or 5 years. But then the responsibility for procurement is spread across 3 national bodies. The National Department of Health and Social Care, which is responsible for the budget and top-line objectives of the NHS, and is ultimately responsible or accountable for NHS procurement. And in relation to pandemics, importantly, it determines what's in the national pandemic stockpile. But then the other thing is that NHS England oversees the commissioning of NHS services, the services that are purchased locally by care groups, and sets a strategy. And then there's Public Health England, which is responsible for dealing with public health emergencies. So you can see that there's a set of responsibilities that may not always be very clear at central level, and 2 kinds of procurement. Can I have the next slide, Nelson? So I want to talk about a situation where decentralization occurred because centralization failed. So this is a central system that didn't work, and it's the case of personal protective equipment, which we've also heard a lot about. So personal protective equipment is supposed to be, and is probably well set up with being a centralized function. As I said, goods are centrally procured in the NHS. But PPE is against a backdrop of a worldwide shortage of PPE when COVID started. The UK stockpile, as we know, has been too small, and there's very little UK manufacturing capacity of PPE compared to some other countries in Europe. On top of that, the national supply system for PPE were unable to get resources to where they were needed. So even when there was enough PPE, it couldn't get to where needed. So you have a centralized system that, again, with PPE failed. But what they did there was, rather than trying to keep the centralized system working, in order to get enough PPE, they pushed procurement down very fast to local level, as well as at this central level. So procurement ended up being done at a local level, often by frontline clinical staff. And that was especially the case in the non-NHS health part of social care, in care homes. The outcome of that was a severe shortage of PPE, or rather, even if not a national shortage, PPE not being in the right place, therefore staff being unprotected, a huge diversion of clinical time from providing patient care. So NHS consultants in some cases were sourcing PPE for their own hospitals. And that had devastating consequences in some cases for NHS and care home frontline staff, as well as for patients. So this is where you had centralization, but it couldn't deliver what it was meant to do. I finally want to talk about a situation where I think the centralization, decentralization worked. And Nelson, if I can have the next slide. And this is, I think, appropriate centralization in procurement. So I'm now talking about procurement in services. So as I said, procurement in services is actually generally done by local level, by what's called care commissioning groups. However, in response to the pandemic, and in response to the fact that the NHS runs with very close to full capacity, as COVID-19 patients began to put incredible pressure on the resources in NHS hospitals, NHS England, a centralised body, took over local powers to purchase services. They simply stepped in and did that. And what that allowed them to do was that it allowed them to buy spare capacity in the private sector, in the private hospital sector, en masse with central contracts. And that gave it greater ability to support the provision of services across the NHS during the crisis. Another example of that actually is the building of Nightingale hospitals, organised centrally, even though services are generally procured locally. So in this case, the centre stepped in when decentralisation wasn't appropriate and managed to build up capacity in the NHS to prevent it becoming overwhelmed by the number of COVID cases. So I'm going to stop at that point and hand back to David.
Thanks, Carol. Thanks, Nelson. So do stay on screen. So we've had a lot of questions here. So, but please keep them coming. Perhaps to start with, let's pick up. Carol, you mentioned Germany as a poster child for track and trace. Is that a relevant comparison, given the German structure and government and structure of government and health is so different to start with?
I think it's a very fair point to make. Should we be comparing ourselves with Germany? I think partly I'm comparing us with Germany because I think it shows how you can manage track and trace in a pandemic. And it is also so decentralization. I mean, in theory, public health functions are decentralized in the UK. And that's where they should happen, especially for things like when you want to make people do things they don't necessarily want to do, and you need to make them do it fast. So, for example, public health knows about local outbreaks of diseases in factories and things like that. Now, it's true that if we compared ourselves to a much more centralized country, which is France, as Nelson indicated, France has been flirting with centralization and decentralization for a long time. France also had the same kind of problems that we've had in the UK. But I still think it's a legitimate comparison because it says, okay, if you did resource your decentralized public health functions in the way that a decentralized system needs to be, you could have had them achieving the kind of things that were achieved in Cumbria much earlier on. So, I think this, if I can just add something to this, I mean, this needs to be seen in the UK and particularly in the UK against a backdrop of central government over the last 40 years. And this speaks to Nelson's point about fashions or about trends, to having a large swing towards centralization of government functions, taking power away from local authorities, stripping them of their tax-raising functions. So this needs to be seen against that backdrop. And that backdrop doesn't exist in Germany, where it's a federal system, where the Länder are strong and are allowed to have different policies and indeed explicitly have different policies on many things.
Thank you. So we will move off this, but there's clearly some energy on this topic. Santi Fernari asks, okay, so should government reverse its decision on centralization versus decentralization on test and trace?
I think it clearly is, in the sense that it's realized that Cumbria does better than the national system. So finally, I think after 6 months, we are seeing much more of a role for public health locally. But there have been complaints all over the summer, I think, even though that role might have been realized, that local bodies did not have the information in time from central government that they needed. So although government's saying they want to do it, central government saying they want to do it, they are having trouble, I think, realizing that aim. And we can see it in that local politicians at the moment are saying we can't make decisions about whether we ought to go into the highest level of lockdown because we haven't got any data that's younger than a week old. So I think one of the problems here is the problem that I referred to, which is that local government isn't really very trusted by central government anymore in the UK. They're nervous about this, and they therefore don't give the resources to local government to do a lot of this. And therefore we're left in this rather uncomfortable position where I think everybody recognizes there needs to be much more a role for local track and trace, but they have been stripped over the years of the ability to do that in terms of resources and personnel.
It's also, I think it's a difficult for in the UK right now, if you decentralize track and trace, you're going to have different outcomes in different areas. And for politicians, that's super sensitive. So they're in quite a difficult position because track and trace decentralized would probably have a better impact overall, but it'll be really variable. In some areas it'll work really well, in other areas it won't work so well, and that will be a political problem. So they have, you know, their job is not an easy one. As much as I don't sympathize that much with them much of the time, I can see in this case it's decentralizing it, they're going to be asked, why is it so different in X local community than Y local community? Isn't this yet again unfairness across the UK? So yeah, so I think that if you decentralize, there will be differential outcomes in different places. That's just part of the game.
Yeah, and that's something that the British system is not well placed to cope with. We have a single national tax system, which includes taxation for the NHS and indeed most public services, because only about a quarter of the resources for local services like education are raised at local level. And that creates this whole idea of a postcode lottery to which the British public appear to be very resistant.
Let me, you've answered in that discussion, you've picked up a couple of questions already, which is fantastic. Neve, I think your question's been asked. Nelson, your discussion suggested that decentralization should be the default. And you shared a model on that, but doesn't it require a whole slew of other cultural or behavioral enablers to make that work? And in the discussion you just had, you touched on trust.
Yeah, I think that's because when I'm thinking about it and I'm thinking of the kind of organizations, corporations, firms, I think it's very different in different kinds of organizations because what you're trying to achieve is different. So the conversation that Carol and I were just having, if what you're trying to achieve is equity and fairness, then decentralization, there's a problem with that unless you're really careful in terms of governance and funding, and you're going to have to fund some areas more to get the same outcome actually. And that's going to be tricky, and that's tricky for governments, and it's in companies. I think it's large companies, especially that are geographically dispersed, then you end up wanting to have a lot of decentralization because that gives them a lot of local responsiveness. And so actually local responsiveness is actually quite valuable for modern companies much of the time, not always though. I mean, for example, if it's a company that runs nuclear reactors, you probably don't want a lot of local customization of safety procedures, right? You really want that centralized and really controlled from the center. So you have to think about what are the factors that are pushing for decentralization versus centralization, and even things like corporate culture or organizational culture or national cultural preferences. And that, it's certainly the case that the Chinese system is pretty centralized, and that's a reflection of their political system and their sort of the place they are right now as a country, and that pushes them to a much more centralized than Germany, which Carol's talking about, or Switzerland, which is even more decentralized in pretty much everything they do. So there's lots of interesting things pushing different ways, and depending on the kind of organization you're talking about, you're really focusing on different things. Is it fairness and equity, or is it profitability, or is it innovation? What is it you're trying to get that helps you think about how decentralized or centralized?
Okay, but so allow me just to press a little bit more, because it touches on a few questions, which is that idea of the 10% saving, which is a very much a financial view of this. And indeed, when we see creation of shared services and the like, it's often financially driven. But aren't there a whole host of capabilities and behaviors whether it's hard stuff around systems or soft stuffs around behavior, that need to be in place to enable that decentralization?
Yeah, well, that's true both directions, right? So it's whether you're moving towards a more centralized system or you're moving towards a more decentralized system. Either way, that's going to involve creating new systems, processes, the changing culture. There's a whole, either whenever you're moving along that continuum, it's going to require some. So Carol's example of test and trace, with all of those companies that were outsourced, it was because the government didn't have a centralized test and trace ability, and it didn't have time to build it, so they had to outsource all of these pieces to 5 or 6 or 7 different suppliers because they didn't have those capabilities. And this is always, there's always new systems, new processes, and it could be either direction. Now, should decentralization always be the default? Probably not. But if the question about profit or other kinds of outcomes, I think the problem is often centralization arguments are about, if we do this, it will be more efficient, and no one has a number, or no one has a way to measure a number. Just, it must be more efficient if we centralize. Well, show us, right? And that's the point of that bit of McKinsey's model, is just to say, show us it from your best guess, and what's the numbers you think we should expect here, not just, oh, let's centralize, so for sure that'll be more efficient, because that's where the mistake meant. And also the reverse, decentralize, because it will be more locally responsive, but then you need to think through what are all the other impacts of that, right? It depends what you're trying to do. But yeah, I think the biggest mistake is centralization without really having a quantitative answer for what are we actually going to save, and is this actually worth it?
And can I add an example that's an NHS example of exactly that kind of centralized without thinking about the cost of it, which is the NHS's, over the years, the NHS's role in digitalization of its services, which were originally sort of electronic health records or electronic use of data, was started at a very decentralized level, often by GPs who were interested in using more technology. And over the years, it's been centralized into these big functions that we will have a national electronic health record system. We will nationalize all of these kind of moves towards digital health. And I don't think for a long time anyone actually kind of counted the costs of that. And that clearly you don't want it all done at very decentralized level, but you probably want it done somewhere in the middle, simply because the cost of realizing a huge national central system where you have many, many organizations involved in delivery, most of whom are delivering at local level. You don't travel miles usually for your healthcare. Nobody actually asked the cost of, is it going to save more than 10%? And I suspect if they'd done that, they would have found no, because actually getting innovation into the system by centralizing that much hasn't proved in the digital space to be very useful.
Okay, thank you. So I think we started touching this, but let me just explore that a little further. Question from Joanne Linder. Are we going to touch on distributed systems rather than discussion to date or so far, which has been much more about the sort of binary, centralized versus decentralized?
So I guess at one end of decentralization, if you're highly decentralized, you end up with something that looks quite a lot like a distributed system, lots of local capability, responding to local needs, or dealing with local demand, or depending on the kind of organization that it is. And so I think the fact that centralization, decentralization is a continuum. On the very far end of it, you get something there's no central control. That's the anarchists in terms of political systems. Just local things run locally for local people. All the decisions made locally. You certainly can think of companies like that, Visa, right, or these kind of big distributed kind of organizations. And Carol was talking about technology. Digital technology makes this completely distributed kind of model more and more not just doable, but common. But what's interesting, and I think Carol's examples are really great for this, is that in any large organization, so as soon as you get very big, as soon as you have thousands of organizational members, there's many, many different decisions that have to be made about different systems and how distributed. So Joanne brings up distributed systems. And I think that idea of the HR system versus the innovation system versus the manufacturing system, whatever, all these different, this very complex decisions need to be made about each one, and they're going to end up on a continuum from very centralized to very decentralized, each one requiring very careful decision making, and not an assumption that in our organization we are here on this. We like centralized systems in our organization. That's not the right answer, right? The right answer is, for this activity, given these constraints and where we are right now, where should we be pushing this, right? And organizations shouldn't have a preference for one or the other. They should have a leadership that's able to think carefully about this and think about, and it's also how much can we spend to move it. So it would be great if we were way decentralized, but the cost of, or way centralized, Carol's example just of the health information system, but actually the cost of that is so huge that the gains we get from that are too small to justify that level of centralization. It could also be true with decentralization. Given where we are and the systems we have, to completely decentralize this would be just so expensive or so inefficient, it's just not worth it. So it's, where are we, where's ideal, and then where can we actually get to that's sensible, right? And with each of these parts of the organization. So this is a really core leadership challenge, thinking through all of this stuff. And the government kind of didn't do such a terrific job, but they did a good job in several different dimensions.
So bring us back to the opportunity, perhaps. We've seen some things that work well and less well. A question from Chloe Y here. In the current COVID context, many organizations have staff working from home. Perhaps we're more decentralized in our working practices since the early 19th, even 18th century. Do you think organizational models might now go through a similar change, as we all are? As you can see, we're all working from home right now.
So there's a couple of things that push decentralization, and that's exactly right. One of them is technology that allows people to work in a distributed fashion. That by definition means things are more decentralized. Also, we know that higher skilled, more motivated employees tend to seek out more space. They want to take on more. They want to be given boundaries and then be allowed to work within those boundaries. Teams want to take on more. That's been another trend along with technology. And I think, obviously in the last 6 months, we've gone through a huge kind of distributing activity in people all over the place and figuring out new ways to work in teams that aren't ever meeting anymore. And that is pushing organizations to recognize that and figure out how to manage that better. So I think there's a bunch of things pushing for decentralization. I think as we come out of this, though, the problem will be cost pressures on companies who have taken a hit from the coronavirus, the pandemic, will push them to look at centralization as a way of reducing costs. So you're going to have two pressures. One is the pressure from new technologies being adopted, people getting really good at using them, being more decentralized, wanting to be more decentralizing, seeking out more scope in their work, combined with concerns at the center to keep costs down, because we're in a pretty difficult situation following the pandemic for many companies. If you're British Airways, they're going to be looking for every way they can to centralize, to save money, because they've lost a huge amount of money, hundreds of billions. So this is many billions. So this is another. So you have this really interesting thing happening in these large organizations, and we'll see where it lands in the end.
I'm not sure this is a great question or not a good question, but let's give it a go anyway. From a Josh L here. I've become, some of these questions are now getting a bit more personal, which is great. I've become accustomed to how my firm works, read functional. I've become accustomed how it works or doesn't. How do I know whether I'm working in a centralized or decentralized environment?
It's really about where are decisions made and how many places are decisions made in. Okay. If decisions all go to I don't know how big the organization is that the gentleman is referring to. But if there's departments of 2,500 and those departments are run extremely centrally, with one leader or a small team that makes all of the major decisions for that department, that's quite a centralized organization. If there's teams or smaller groups that make lots of decisions about what they're doing and where they're going, what customers they're going after, whatever it is they're up to, it's how many points of decision making there are. If you remember those figures that I showed you, the nodes in those decentralized and centralized organizations, those are decision makers. So this is about where decisions made, how many people are there, who's shaping the activity that's going on, and how many of those people are there. Right?
Can I add to that? I think it's also about where strategy happens.
Yeah.
So the NHS is a good example of the fact that it's got 1.3 million employees, and that's not even starting with family doctors. And obviously an awful lot of what happens in a GP practice or what happens in the cancer department at hospital X decisions are made completely at local level by the appropriate clinicians and their support. But strategy for the NHS is very much determined at central level, which leads to a vast amount of what's being called reorganization of chairs on the Titanic, in order to move towards a model that is more efficient, and often argued to be, just to change models. And that changing of models happens mainly at central level. An example where the pandemic did that quite well was, for example, how to run cancer services the minute COVID happened. And what happened was the NHS clinicians drove local solutions, but not in their own hospitals, but across hospitals, partly helped by this national procurement of elective surgery at private hospitals. So there was, for example, a Northwest London response in cancer services led by clinical teams. So it wasn't actually your local hospital that did it, but it was a collection of hospitals taking an appropriate sort of regional sounds a bit big because of how English regions are, but appropriate kind of larger than a local hospital approach. And that has worked. But the decision makers there were within the central function. It was given to local decision makers, not necessarily a decision maker per hospital to drive the strategy, but a group of people who drove that strategy.
Let me build on that a second, and somebody's picked up on your research around equity, Carol, which is that Id Adedugbi, I'm a doctor working in the NHS, and his comment is around there are some systems which are patient records, for example, which are probably very well suited to being national, and he mentioned some other ones. But might local decentralization and therefore some localization, will it increase or decrease inequality, or what some of the papers called, postcode lottery?
I mean, this is the constant tension in Britain because we have such a central government, centralized political system with, as I say, for the NHS, national taxation, which means that we're driven all the time to this comparison around equity, which is often around spatial equity, and a fear that allowing local decision-making will allow one place to be better than the other. The reality, of course, is there's a huge distribution in productivity, across the NHS at local level, a huge distribution across different services. Some areas will have good services in one area and not another. But there's not much political capacity to deal with that distribution. And so the tendency is always to put out central directives to say everyone must do things as much as possible the same way in order to overcome these local differences. But we tolerate local differences in non-public services quite a lot more than we tolerate local differences in services. And indeed, we tolerate local differences in schools more than we do in hospitals, I think. But it is a tension that comes from this real strong desire to centralize that's been happening in UK government and UK politics over the last 40 years and maybe before that. A central state has this problem in spades.
There are so many more questions I want to ask, and I was going to try and squeeze in a couple more, but I don't think we're going to be able to. So we're going to have to reflect on what we deal with the other questions. So, so I think we will pause it there. I just want to do a couple of things, which is firstly, Carol and Nelson, thank you so much for a marvelous presentation. There are many students, executive education students, that have the benefit of spending time with you. I'm reminded how good it is to have real experts share insights and help guide our thinking. Thank you to the many attendees for asking questions and indeed testing our thinking. Please visit our website for more information about the work we're doing around leadership and health. Several have asked about can I access this? So the recording and slides will be available on the website shortly. So a couple of things coming up. Nelson's course, let me just move that for a moment. Nelson's course on leadership in a technology-driven world is coming up in a few months' time, and we have another webinar coming up in November, date still to be confirmed. Check the website, which is really going to explore, an element of this that we've been talking about today, but also how do we develop a customer-centric organization, which clearly has overlays of what we've been talking about today. So that's coming up in November. Professor Regis Bhargav. And so let me close. Thank Carol, Nelson, and you for joining Imperial Future Matters webinar. Thank you.
Thank you and goodbye.